say, all of that sounds great, but where is my grandkid, right? So the challenges. So I want to share the story of how Latinas in medicine came to. I came to this country with a scholarship. My country has been in a political turmoil since 2005. And I was a pre-medical student during the first coup. And that led to me applying to a medical scholarship that took me away from Venezuela and with very minimal English. I remember landing in the United States and being told right away, oh, you're a Latina, you're spicy. And, I didn't have good English. It's like, spicy? I don't need spicy. I had gastritis. And I was understanding how I was labeled as someone right when I landed. This is me as a second year resident, 20 pounds lighter, less wrinkles, but now I have more knowledge. But these are some of the interactions. And during my training, this is the CCU at Rutgers, led to sense of isolation. I was called too passionate. You are so fascinating. I actually was told that last week still. You're so out of the box because we have what the standards of what doctors supposed to look, sound, and say. You're too ambitious. This is related with gender, right? If you're very proud if you're a woman, you're too ambitious. You are so Latina. I still don't understand what this is. I promise I know walking around with a pineapple in my head and only speaking Spanish. This is the one that still gets me to the core. You're so smart for a Latina. And they all come from interactions. Due to this, it led to clinical depression during training. And believing I didn't belong in medicine, and I'm a fourth-generation doctor. I almost left medicine. This is something for oncology, which is our tech talks, to share how eventually I was so exhausted to trying to be somebody I wasn't, because I changed all my wardrobe, black, gray, and navy, to fit in on what I supposed to. I didn't share my experience with my co-residents because none of them have experienced two coups in their lives. So I refrained for that. I refrained for sharing my relationship with my abuelita because it was very different. And that led me to feel like I needed to put my white coat as a costume and change who I was. But finally realized that I was here to change the status quo, to mentor people like Gabriela, and to make sure that everybody has a space. So as a result, with two amazing doctors, we co-founded the Latinas in Medicine group. It all started with a tweet, and we registered the hashtag. That started even before the lab. That was in 2017. I was in Rochester, Minnesota, in elliptical and another polar vortex. If you're from Minnesota, you get a lot of those polar vortex. And we came because Latinas come in different colors and forms and shapes, and it was very hard to identify each other in conferences. So we started with a little ribbon called Latinas in Medicine that you would put in your badge so people can self-identify. And this is a Latina in PM&R in 2019, and she made this picture for us. She was lonely, but thanks to the ribbon, she identified Monica, and now they're besties. So we also have Latinas going to kindergarten, going to high schools to show the Latinas that yes, you can be a doctor, you can be successful. This is our first publication for Latinas in Medicine. We created a hashtag to identify the tweets and to amplify the Latinas that are out there, because we know women of color are less likely to be amplified on social media. So we wanted to create equity that way, increase visibility. And this was our first paper in the Journal of Graduate Medical Education. So we have an outreach community to assure that the experience I have and many other Latinas didn't become a reality. This is our Twitter account. Now is over 10,000 members. We try to have mini interviews of upcoming students, residents, to amplify them. And this is the paper that Gabriela will talk to you later. So we always wonder, is our experience, Gabriela and I, unique to medical education? Is it unique because we're outspoken? Is it unique because of where we were in the Midwest? She's still there. I moved to Boston, but she's still there. So we started with the first survey to describe the Latinas in medicine training in the United States. So this includes residents, fellows, and more. And you're gonna have the results from Gabriela. It is not my role to talk about. But Latinas in medicine goes beyond this. We realized that ASCO in the 50 years, this is the American Society of Clinical Oncology, had funded only 3 Latinas in their grants over time. And I was like, this is unacceptable because you get around 20 to 25 awards every year. And we know that Latinas in oncology are leaving, particularly after the pandemic. There's a big exodus. It's not only in oncology. WANC data shows that gap between assistant to associate professor, a lot of Latinas and other minorities or underrepresented groups in medicine are leaving. Like another mentee told me, would you stay in a place that continues to remind you that you don't belong and it doesn't help you fit in? When you can go somewhere, make more money, let's be very honest, and not be dealing with the challenges of academia. So because of that, Dr. Gladys Rodriguez, which is an ASCO member, ASCO board member, and I decided to take this in our own hands in 2020. And we started fundraising, ground up. Every single of my uncles gets a text message once a year to donate to this. And we have been able to fund 5 joint investigator Latinas in oncology. That's why we always wait for systemic change, but the power of 2 and sometimes the power of 10,000 is very, very powerful. We just fundraised for the next year award, and we have that money. So we have funded more Latinas in 4 years than ASCO did in 40 years. And that's the power of community. That's the power of Latinas in medicine. The Flores Lab, previously known as the Duma Lab, little rebranding due to situations, has been here to change how we mentor underrepresented women in medicine. We cannot use the same formula for everybody. Everybody has different needs, family responsibilities, understanding, experiences. So something that's very important to remember is that diversity without inclusion equals trauma. And that's what happened to me. I was recruited due to diversity efforts, but nothing in the hospital environment changed. And that led to like, I'm here, you're not ready for this. And all these negative experiences. This question is not to be answered right now, but to be answered after Gabriela's presentation. What can you do to create equity in medical education? Not only about Latinas in medicine, but many other groups beyond race and ethnicity, disability, first generation college grads, first generation doctors. I come from a privileged background that both my parents are surgeons. But somebody who doesn't come from that is very difficult. Financial challenges, student loans are many things that often are unspoken, but they're part of who we are. So what can you do to create equity in medical education is your question for today after Gabriela's presentation. And I want to show the biggest, proudest thing. Gabby's not in this presentation. This is part of my lab. Majority of them are women from underrepresented groups in medicine. Some of them don't jump because they were pregnant at that time. But this is the Flores Lab. We're here to change how we do things. So I'm going to stop sharing my presentation, and it's my pleasure to introduce a student, Dr. Geiger, who did the study, did all the hard work, and she's going to show the results to you.
All right. Thank you so much, Dr. Flores. Let me just share my screen here. Okay. Can you see it good? All right. Well, thank you again, Dr. Flores, for the words and for your mentorship over the years. I know that I would not be where I am without that. So just appreciate it as always. And thank you, Dr. Karani, and all of you for having us here today to speak. So like was said, I'm a third-year medical student at the University of Wisconsin School of Medicine and Public Health. And I'm here to talk about the study that we conducted with the Flores Lab. Like Dr. Flores talked about, she created this lab out of a need for systemic change and founded this lab, and we do a lot of work with not only cancer health disparities, but also discrimination in medical education. And it's fitting that our presentation lands today, which is the last day of Hispanic Heritage Month. So we thank you for having us here to talk about that. So let's begin. I have no conflicts of interest to report. All right, so some learning objectives for today's presentation. I have a few: to understand the significance of representation and diversity in medical education, to identify the unique experiences and challenges Latinas in medicine face throughout medical training that may impact their academic performance, career progression, and mental health. And then identify strategies that institutions can implement in order to promote a culture of inclusivity and belonging. So to begin, I wanted to set the stage on why we decided to conduct our study. So Latinx Hispanic is one of the fastest growing populations in the United States, comprising approximately 19% of the total population, and this number is only projected to increase in coming years. As we all know, there have been numerous efforts to increase diversity in the past decade and beyond, but the physician workforce still does not mirror the ever evolving population it serves. And this is especially crucial in states such as California, where the Latino population makes up about 40% of the total population in the state. So Latinas specifically make up 9.39% of the US population. The amount of medical school matriculates that identify as Latina has increased in recent years, and with the most recent data from the AAMC showing that 5.8% of medical school matriculates from 2022 to 2023 identify as Latina. And then despite the increase in ethnically diverse medical school cohorts, only 2.4% of practicing physicians are Latinas. And this raises the question as to whether there are certain factors that may be causing Latinas to either not pursue a career in medicine and go to medical school in the first place, not complete the entirety of medical training, or, as Dr. Flores touched on, leave a career in medicine early or at any point. So some might question why this all matters. Well, there's been an abundance of research that shows that racial concordance between physician and patient improves care in many different ways, as it increases patient satisfaction, increases the likelihood of patient receiving preventative care, which we know is incredibly important, and allows for the ability to speak to patients in their native language, which in turn leads to increased understanding and better outcomes. And then also increases the likelihood that a patient will follow up with care. Spanish is the #1 requested language for medical translator services here in the US. And while translator services are an incredible service to be able to provide for our patients, it does not replace the need for providers that are fluent in both language and culture. I personally have seen this time and time again, where you see how much more a patient is willing to share and how much more comfortable they are when the physician themselves speaks Spanish versus using a translator. It really just opens up the conversation a lot more. And I've also seen just a sense of relief wash over patients' faces when I or someone else walks in and they're able to speak Spanish. It's almost an instantaneously just sigh of relief, and then they start going in. I've even had at times where there's a doctor that's using a translator, and then I start speaking to them in Spanish, and I've had patients start crying because then they felt like they could actually share a lot more and get into what they really wanted to say without feeling awkward with the translator and an iPad speaking to them, basically. So in addition to these benefits, students that train at institutions that are that have more diversity within the student population and their faculty are more apt to consider things like cultural preferences, race and ethnicity, religion, and other social determinants of health. in clinical encounters. So this ultimately, again, leads to better patient care overall. And on top of this, all physicians who are URM are more likely to practice in underserved and low-income communities. And given this information, the fact that the Latino population in the US is around 19% and increasing, it's imperative to the health of our patients and that the number of Latino and Latina physicians increases well beyond what it has already. Data also supports that attrition is high in URM trainees, URM here, underrepresented in medicine, the groups that we're aware of. And then this indicates a need to better understand factors that could be leading to this attrition. So in addition, minority women have especially been victims of discrimination and marginalization in the medical workforce, as women in general have long faced intense challenges during medical school and well into independent practice as well. So previous research observes a positive correlation between the number of marginalized identities and the risk of mistreatment and discrimination. So our study population, Latinas, have, the female aspect also being URM. And then the other things that Dr. Flores touched on of sometimes, first generation in medicine or needing financial support, also immigration, if you're coming in from a different country and all of the different visas that are required and things of that nature, it just compounds. So when looking through data about experiences of URMs in medicine, there was a significant lack of data specifically regarding Latinas. So we conducted the first study to evaluate the experiences of Latinas in medical education here in the US. So before jumping into the results, I'm just going to talk a little bit on the methods. We wanted to hear directly from Latinas in medicine in order to do this study. So with the help of experts in the field of health equity and medical education, we created a 65-question survey that had both multiple choice and open-ended questions for short answers. And our study was approved by the IRB board at UW-Madison. So for recruitment, we primarily use the Latinas in Medicine Twitter page that Dr. Flores touched on. And then we also use 22 different LMSA or Latino Medical Student Association chapters. We chose these ones because these were the groups that had updated information on their websites with emails of current leadership roles for their LMSA chapters. So to be able to take this survey, you needed to be 18 years or older, self-identify as Hispanic Latina, and currently completing or have completed at least a portion of your medical training in the US within the past 10 years, and then to be able to complete the English and survey as well. So in total, we had 230 respondents for our surveys, and due to the sensitive nature of some questions, participants were able to leave questions unanswered if they wished. You can see here the demographic table, a few of the characteristics. Age was broken down into multiple categories, so I just shortened that there. But the largest portion was for respondents was between the ages of 23 and 27. That was 39.6% fell into that group. 10.7% identified as Afro-Latina, 12.4% identified as being a member of the LGBTQ plus community, and 44.9% were born outside of the US. The majority of our study participants were current medical students at 46.9%, but we had a good number of respondents across training. And let's see. Here we go. So jumping into some of our results. While we were thrilled with the turnout of participation we received and just the enthusiasm surrounding the project, we were deeply saddened by the results. So URM trainees, unfortunately, as we know, face discrimination in the workplace, and 54.5% of respondents reported having had negative interactions with patients or their patients' family members that stem directly from their ethnic identity. And on top of that, an astounding 72.8% reported experiencing discrimination from others in the medical field. So their own colleagues, their own teachers, their own peers. Other studies have shown that female URM trainees make up the largest portion of incident reports, and yet the majority of our participants indicated that they did not report the incidences of discrimination that they faced. So that indicates that a lot of published data out there surrounding incident reports is probably a lot lower than the actual value. These numbers are even more staggering when you consider previously published data that analyzed the AAMC graduation questionnaire responses that showed a much lower incidence of discrimination within the general medical school population. So only 23.3% of URM graduates in those surveys indicated having experienced discrimination based on their race or ethnicity. So that is a much lower number than what our study respondents said. Experiences with microaggressions were also highly pervasive. So 61.1% of participants reported being mistaken for other colleagues. 84.8% reported instances where they were assumed to have other roles in the medical setting than their true role as either a medical student or a doctor, including janitorial services, food services, or nursing staff, which these are roles that oftentimes there's a stereotype of this is a Latino position or a female position. And medical school and residency are the phases of training where these occurred most frequently. Mental health struggles were also, unfortunately, very, very common in Latina medical trainees. Our survey showed that 76.2% of Latinas experienced feelings of depression and/or depressive symptoms during medical training. And when asked when these experiences took place, they could choose all that apply, but medical school rates were by far the highest at 82.5%. And 82.5% is already an incredibly alarming number. But to compare, a large meta-analysis found that approximately 27.2% of medical students experience depression or depressive symptoms during medical school. So there is a stark difference in how Latina medical students are going about mentally and mental health wise during training compared to the general medical student population, just higher rates of depressive symptoms overall. Similar findings were seen when asked about anxiety throughout training, and an overwhelming 92.6% of respondents noted having struggled with anxiety during training, specifically, again, 82.4% during medical school, which was the highest. And though still prevalent at different stages of training, it decreased. And to make a comparison, again, there was another meta-analysis that showed that approximately 33.8% of the general medical school population struggles with anxiety during medical school. So again, just a very large difference in those numbers. So our sombering results are consistent with previously reported data of marginalized groups in medicine and reveal how Latina medical schools students specifically experience depression and anxiety at much higher rates. The topic of mental health is also, it's historically been a very stigmatized topic in the Hispanic culture. And there's a belief that one must be mentally tough and be very private about your mental health and your health struggles. So many go without seeking help and suffer in silence due to this multi-generational cycle of stigma. We did not necessarily ask directly about if they sought treatment during training for any of these issues of depression or anxiety, but it's important to look at the already existing data within the Latino population regarding treatment for mental health. And according to NAMI, the National Alliance for Mental Illness, 35.1% of Hispanic adults with mental illness receive treatment annually. So there is a big portion that don't seek treatment. And there were multiple open-ended responses that did kind of touch on the stigma and how the stigma in their community or from their family impacted how they went about with receiving treatment during training or not. Okay, so burnout is a state of mental, physical, and emotional exhaustion that can be caused by chronic stress. And it was important for us to address burnout in our survey, as it's been shown to be connected to depression and is associated with leaving the healthcare profession, lower patient satisfaction, and impaired quality of care. And our results for this were also sad, as 87.4% overall indicated having experienced burnout during training, with medical school again being the time in training where it was most noticed. And then when asked about imposter syndrome, 90.7% suffered from imposter syndrome at some point during medical training. And 77.8% of those indicated that experiencing imposter syndrome affected their performance in training. As with the previous slide, medical school was the point of training that had the highest rates of imposter syndrome. So mentorship, as we've already touched on in this discussion with the mentorship relationship that I have with Dr. Flores and she has with a bunch of her mentees, is important for anyone in medical training, but specifically URM trainees greatly benefit from mentorship. So much so that it can actually serve as a protective factor for things like burnout and attrition. So it was important for us to include this topic of mentorship in our survey to identify if this is an area that institutions can put more emphasis on to better support Latinas during training. And we found that 54.8% of study participants believed that the mentorship they received during training was inadequate when compared to that of their peers, and indicated again that medical school was the time in training that was most difficult to find mentorship. So in addition to the quantitative analysis that we conducted from the survey that I just talked about, those results, we saw an importance of conducting a qualitative analysis as well, as our survey included multiple open-ended questions. And we were very fortunate enough that our participants were gracious enough to give even more insight to what it is to be a Latina in medical training with their own words. So this specific data at this time has not been published, so it's just something that we asked is not shared on social media. But in analyzing the data, we identified 3 overarching themes in the responses. So Latinas face numerous barriers in medical training associated with their limited social, cultural, and financial capital. Latinas face numerous forms of bias and were undervalued in their medical training, and the intersection of the burdens experienced during medical training culminated in substantial mental health inflictions, as we've already seen by the data with depression and anxiety. So in the following slides, I'm going to share direct quotes that respondents shared in our survey, because I think they're really powerful. "I wish I had met some more Latina physicians throughout my training. I just realized I've never worked with any, and I've only heard from them from afar, but I would have loved to have them, especially as a mentor." During residency, a lot of burnout related to not being valued or taken seriously as my peers unless I work harder than them to be seen as equivalent or as smart. Lack of mentorship due to feeling different from the current mentors that were available, not feeling like enough, not appreciated for the extra work such as translating and being mindful to be culturally sensitive to Spanish-speaking patients and families, and this not being recognized when other Anglo peers who do the same or less get that recognition. And I think that this participant brought up something that's really important and something I want to talk a little bit more about is she mentioned translating. So this was something that came up multiple times in the short answer questions. and something that I've noticed with myself and peers. While most individuals who speak Spanish are more than willing to help out with translation here and there for other patients that might not even be the patients that they're following, and they're just helping out a colleague or someone. It also adds on another task for them to do and can potentially take away time from their other patients and other responsibilities. And in some ways, this can be an example of what we've heard of a minority tax, which is a term used to describe the additional responsibilities and challenges that URM faculty and students experience in medical institutions. While again, I would argue that most students and trainees who speak Spanish are happy to help with translating, as we do know that it's so important for them to receive care in their native language. It's just important to realize that, as this participant stated, it can also create extra work in their day and potentially lead to feelings of undervalued or under recognition for taking on those extra responsibilities when it's seen as just something, oh yeah, well, they'll do that because they speak Spanish. So it's just another thing to think of when interacting with Latinas in medicine. It is like walking on shells. Also, we work in a man's agenda, with meetings at 7 a.m. or before. We are being excluded from important roles in hospitals because we have other roles at home during that time. It is not fair. We speak up and all people see is a sassy Latina. Others speak up with no labels or judgment. The fact that you have to be strategic to get to people is energy wasted that can get you burnt out easily and leave the medical field. Even when I love my career, the barriers that I find as a woman, Latina, are driving me to think of early retirement. This quote specifically, part that the participant talks about being sassy, reminds me of the piece that Dr. Flores talked about that she wrote of "My White Coat Doesn't Fit." And as she talked about it a little, I won't go too in depth, but I just really recommend, if it's something that you have not read, that you take a minute to do so. You can just Google "My White Coat Doesn't Fit" and it'll come up. But it's a powerful piece of writing that highlights the struggles of feeling out of place in a very demanding environment, the pressure to conform or lessen your personality and identity, and just the overall emotional toll of navigating a field that is really lacking in diversity. Rough, isolating, depressing, excruciating. And then created a little word cloud of another open-ended question that just asked to describe your experience in medical training in a few words. So, struggle to feel like I belonged, discouraging, lonely, barriers, alienating, diversity tax, my biggest regret. So the data generated from this study shows that Latinas in medical training, specifically during medical school, are experiencing rates of discrimination, depression, anxiety, burnout, and imposter syndrome at rates alarmingly higher than the general medical school population. And the reality is that Latinas in medical education in the United States are struggling. What I find also incredibly alarming and worrisome is that in recent years, there has been a shift as institutions try to prioritize mental health, try and increase ways that they can support their vulnerable students. And yet a large majority of our study respondents were current medical students. So the ones who are supposedly supposed to be benefiting from this change, from this shift. So it just shows that there is a lot of work to still be done. And just overall, we expand on previous research that does observe that the positive correlation between the number of marginalized identities that I talked about earlier, and shows that discriminatory experiences based on intersectionality also result in psychological decline, like burnout, emotional exhaustion, self-doubt, and overall job dissatisfaction. So the question is, how can we best support our Latina trainees? And I wish there was a perfect answer to this question, but there are stories of success and initiatives that can serve as examples for other institutions to implement. From our data, it is imperative that medical training programs, specifically medical schools, so at the earliest points of training, implement accessible mentorship for their Latina students, as adequate mentorship can be a protective factor for things such as burnout. The Hispanic culture as a whole prioritizes community and togetherness, and that's unfortunately just a factor that is all too often hard for Latino medical students to find during medical training, especially if they go to a school in a state where their family isn't, or, you know, go somewhere in the Midwest where there's not as much of a population and things like that. So mentorship is one way to help find that togetherness and that community that our culture is so centered on. There are programs like the Strive program at Northwestern that is a resident medical student mentorship program, which has demonstrated positive effects of peer mentorship, which I think is a really important aspect as well, because I think mentorship, a lot of times the focus is on medical school and there might not be as much in residency. So I think being able to bridge the two when you have a institution that has both a medical school and a residency program, it's just a great way to be able to, especially because oftentimes they'll be maybe a little closer in age and just have experienced those things in medical school. So that's a great program there. The Latinas in Medicine Twitter community that we talked about, it's just a great way for physicians and trainees to connect. And it's something that schools with either like a small or non-existent LMSA group at their institution to maybe even promote to their Latina students as a way to find that mentorship or just a sense of community, even if it's not necessarily at the school itself. I personally am a part of the Enrich program at UW, and Enrich stands for Enhancing Representation to Improve Our Community's Health. And it's a program for URM students that provides mentorship and experiences in primary care in order to increase the number of physicians who represent our diverse patient populations to improve the health of the community. So this program pairs you with a faculty member who serves as your mentor throughout your training, and you have one-on-one mentorship meetings during that time. You attend workshops and networking events. You receive funds in order to attend academic conferences of your choosing. You work side by side with your mentor in mainly during your preclinical years. During your preceptorship, they work with the school to make sure that you're paired with your mentor. So that way you have like an even more longstanding partnership with them. And then you also get to participate and volunteer at community health events. So the program is newer, and the first cohort of graduates are going to graduate in May. So there's not objective data yet to show the benefit of the program, but just having experienced it myself, I firmly believe that it has had a positive impact on not only myself, but the other participants and my peers. And then given the astounding rates of discrimination that not only Latina trainees, but URM trainees are facing as a whole, it's imperative that institutions implement zero tolerance policies surrounding discrimination. Unfortunately, it is the reality that many institutions provide little support against such actions, and that often results in trainees and physicians often choosing not to report the incidents, as we found in our study, out of fear of different things like repercussion, poor grades or evaluations, or concerns that they might just be playing the ethnicity card. So understanding that all policies, it's not enough to just say we don't tolerate discrimination here, but all policies require reinforcement. It's important for institutions to adopt a zero tolerance policy of discrimination from patients, students, instructors, and something that's widely accessible and anonymous reporting for mistreatment. There's example, like UCLA has a great, they have a lot of real-time mistreatment reporting systems for students and staff. And I feel like it's important to, in these policies, to have it be real-time and to have the action taken be right away or as soon as possible, because oftentimes I've seen even that it takes months and months for them to even get through their list of complaints that they've received, or they'll review them once a year or quarterly. So it's just not enough, especially because it's happening so much. So just a summary of everything that I've talked about here today a little bit. Latinas make up a very small percentage of practicing physicians in the US, despite the Latinos accounting for 19% of the population and growing. Racial concordance leads to better health outcomes overall. So it's important that our physician workforce mirrors the population that it serves. Attrition is more prevalent in URM trainees and physicians. And Latinas face unique challenges and barriers throughout training, and that can significantly impact their mental health and desire to continue on this career path. And it's imperative that institutions reform their culture and provide ample support to Latinas and other marginalized groups in medicine to continue to not only recruit diverse medical cohorts, and as Dr. Flores stated, that diversity without inclusion is going to lead to negative downstream effects. It's almost inevitable. So we have to do better to not only recruit Latinas to the medical field, but to support, retain, and advance them in their careers. So these are all the references from the study. And I will open it up to some questions, but thank you so much for your time.
Thank you.